So when I would meet with an EB family, I would want to know, has your child had anesthesia before? How did it go, and were there any problems? The information that you share with your anesthesia team is very, very helpful to us because we can learn from previous experiences, especially if you had your other anesthetics in a different institution. One key question for us is how the airway was managed and if your child was intubated during the anesthetic. In other words, if a breathing tube was placed in the windpipe, and if that was difficult. If it was difficult previously, then we're really going to be having a heightened level of awareness to be sure things go well. Let's look at some common problems in patients with epidermolysis bullosa in terms of the airway. With time, the mouth opening decreases because of scarring. There's often a lot of lesions in the mouth that are open sores. There can be dental decay, and the teeth are angled inward a little bit, and the tongue is often fused to the floor of the mouth. And all these make it a little bit challenging for us as we put in the breathing tube. So we really want to get a good look at your child before we start anesthesia. Heart problems can also be seen with recessive dystrophic EB. There's something called a dilated cardiomyopathy, which means the heart gets bigger in size and the pumping function of the heart is not as strong as it was previously. And that can pose potential problems during anesthesia. And that may be related to deficiencies of carnitine or selenium. As a result of that, we recommend here at Cincinnati routine screening echocardiograms for recessive dystrophic patients so that we can keep an eye on the heart function over time. Before anesthesia or surgery, it would be nice for us to know what the level of the blood count is to see how bad the anemia is, if present, and to get some renal and metabolic parameters also. What are some of the common operations that patients with EB come for? A wide variety, anything from dental rehabilitation, esophageal dilation for strictures, plastic surgery to correct hand deformities, and gastrostomy tube, I think, are probably the most common, but there's others as well. So what are some general principles? I think this little sign here says it all, that it's fragile, we should handle with care. We make every effort to handle patients very gently. We don't slide them from a stretcher to the operating room table. One thing that we do is we tend to place them on an egg crate mattress and move the whole mattress to avoid any skin trauma. And we avoid any kind of adhesives during the anesthetic, and we leave the dressings that you have on in place as much as possible, just to, again, avoid skin trauma. So what do we do to prepare for things? We here have a kit with all of our supplies, and you can see this young lady who's taking a little snooze for a procedure is on one of these egg crate mattresses and is very well padded. A wide variety of dressings can be used. We've been using the Mölnlycke products here, but there's many others too. And just to provide with protection, one thing that's been a real help to us is the Mepitac tape, which allows us to secure IVs, breathing tubes to help close the eyes. That has really been great for us, and it's very easy to work with. All right, so how do we start anesthesia? That's called the induction process. Often we'll give patients some pre-medication to reduce their anxiety ahead of time. Patients who come repeatedly as children for operative procedures tend to be anxious about them, so we may give some oral or some intravenous Versed. We can use a mask anesthetic to have them drift off to sleep by breathing through a mask, totally painless, as opposed to having trouble starting an IV, which can be a challenge. In some institutions, as a parent, you may be present for the anesthetic, and that can be very helpful. We do that routinely here. All right, so we have our patient prepared. We've started the anesthetic. What kind of considerations do we have for monitors? Typically, we'll use the EKG leads with all the adhesive cut off so that there's no stickiness on the skin that could damage it. And then we'll just cover it with a non-adhesive dressing. The blood pressure cuff is placed over some gauze padding. And in the bottom right, here you'll see the pulse oximeter probe, which is a little device that measures heart rate and oxygen levels. And the style we use is just a little clip that has no adhesive. What about getting an IV? It can be a little bit of a challenge. We do it gently with some padding under the tourniquet, and we place the IV and then use non-adhesive tapes to secure it, and then wrap it up so it stays in place. Eye care is very important. Patients with EB, Tim's laughing because I think this is him here on the bottom right. He thought he was going skiing when he came to Cincinnati, but it was July when I took this picture, so I think he had his seasons mixed up. But you see, he's from upstate New York where there's a lot of snow. So the corneal ulcers can be a problem because of poor eyelid closure. I would encourage you to bring your preferred eye drops or ointments with you so that we can apply those liberally while your child is asleep under anesthesia. It's important to use a preservative-free preparation that does not contain lanolin. We've had some bad experiences with lanolin in the eye causing irritation. And then we close the eyes, cover it with a moistened gauze, and for some patients we do use ski goggles to just help protect the eyes. All right, what about the process of putting in a breathing tube? In younger children, that typically is not terribly difficult. But as the patient grows older, approaches adolescence and young adulthood, because of the continued scarring of the mouth and the mouth getting smaller and scarring inside the mouth, it becomes more difficult. The typical device that we use is this in the right, I'm sorry, my pointer's losing it here, is just a laryngoscope, which is a steel instrument with a light on it that allows us to visualize the airway so we know where to put in the breathing tube. But as the mouth opening gets smaller, it is more difficult to use that instrument. So we will use a special fiber optic intubation equipment, which is flexible and allows us to very gently find the airway and then to put in the breathing tube. Despite our best efforts, it is not uncommon to have some new sores in the mouth after an operative procedure. So here's a patient that's all set for their operation. You can see that their eyes are protected and covered with a moist gauze. The breathing tube is in place here. There's some protective dressing on the face, and we have not used any tape, but rather this cloth tie to help secure the breathing tube. These are some pictures of a patient undergoing dental work. You can see in this situation we put the breathing tube through the nose so the dentist has complete access to the mouth. And there's not much room there, so we really need to make it as easy as possible for the dentist. Sometimes we can do something other than intubation. Sometimes we can use a device called a laryngeal mask airway, which you see pictured here. I'm a little cautious to use that, though, because it goes in the mouth, and it's kind of a soft silicone mask, but it can cause more sores in the mouth. Sometimes we can just use the face mask for the anesthetic if it's a brief anesthetic, and sometimes we really don't need to do anything special with the patient's airway at all. They can just be breathing on their own.